The ideal site has to be over rectus muscle. The surface or the abdominal wall we are planning a stoma has to be flat. It has to be more than 5 cm away from the umbilicus, any scars, skin folds and bony prominences. Otherwise, if it is near umbilicus, it is near bony prominence or it is near to scar, you cannot apply bag well. So it has to be 5 cm away from all these things. Avoid belt line, because if the stoma comes on the belt line, difficult for the patient to manage. And remember, passing the stoma through the rectus will reduce the risk of parastomal hernia and prolapse. In obese patients, consider stoma in the upper abdomen because it has less pannus. In patients who are wheelchair bound, before marking the stoma site, make them sit over a chair. And in complex cases, you can apply the stoma bag in the site and see whether it fits properly or no. You can do a trial appliance for 24 hours. The patient is comfortable, the bag is sitting properly, then you know this is the site you have to do. There is some problem with the bag, the patient is not comfortable, then you can plan some other area. Okay, so for complex cases you can do trial appliance for 48 hours, trial appliance for 24 hours. So ostomy triangle, this has not been asked as an MCQ till now, but they can frame a question on this. What is ostomy triangle? So landmark is ASIS, anterosuperior iliac spine, pubic tubercle and umbilicus. That's the pubic tubercle, this is ASIS and that's the umbilicus, and this is the triangle, and you can have triangle on both sides. Okay, so that is the ostomy triangle. It is defined by anterior superior iliac spine, umbilicus and pubic tubercle on right and left side, and this is where you have to do ileostomy or colostomy. But this side you will do ileostomy, the right side. On left side you will do colostomy. In this triangle you have to do, and make sure that it comes through the rectus. I told you why. Okay. Operative technique, ileostomy, we all know the location. You excise the skin disc. You have to preserve the subcutaneous fat. It provides support when you preserve the fat. You will incise the rectus sheath vertically. 3 to 4 centimeter incision is given. You will split the rectum, don't cut the rectum, you split the rectum, and then you will open the posterior sheath. How much should be the space? It should admit your 2 fingers. Okay, and subsequently you will mobilize the hilum. Remember to leave more than 1 centimeter of the mesentery strip, otherwise your stoma is going to get ischemic. Leave more than 1 centimeter mesenteric strip over the ileum. The mesenteric edge, when you are pulling the stoma through this aperture, the mesenteric edge should be upwards to the cephalad direction, and protrusion has to be initially 5 to 6 centimeter, and then you will mature it, then it will ultimately become 2 to 3 centimeter. So when you mature the stoma, it should become everted because you want to make sure that there is no skin irritation. You have to apply tripartite sutures, dermis, seromuscular bowel and full thickness of the bowel edge. Okay, I am sure you understand what I am saying. All of you have done stoma, so I know you understand what is tripartite sutures. As I told you, the final protrusion will be 2 to 3 centimeter. Do not suture bowel to the posterior fascia for end ileostomy. If you are doing end ileostomy, don't suture the bowel to the posterior fascia. Some people routinely close lateral gutter, it is optional. Okay, and that is what we have discussed. The disc of skin is excised at the stoma site. You will open the anterior rectus sheath vertically. Okay, the stoma site should admit 2 fingers. Then you will bring the ileum, and remember to preserve the mesentery more than 1 centimeter. And this is how you will do a tripartite bites between the dermis, seromuscular layer of the bowel at the facial level and full thickness at the cut edge of the stoma, and you will avert it. And that is called as maturation. You can see, okay, you will pull these stitches and the stoma will get everted, it will mature. Okay, the operative procedure for end colostomy, generally done left lower quadrant. You need little larger hole than ileostomy. Colon is mobilized along the white line of told. You don't generally avert it, you just do it flushed with the skin. I have no personal experience with retroperitoneal colostomy, but it has been described in Shackelford. It has been told that retroperitoneal colostomy reduces hernia, reduces prolapse risk, but it is technically demanding. I don't have any personal experience with retroperitoneal colostomy. Moving on to loop stomas, and commonly we do loop ileostomy. Loop ileostomies are preferred stomas for diversion. They are most of the times preferred for temporary diversion. Where do you do loop ileostomy? 15 to 30 centimeter proximal to IC wall or to the pouch. Both limbs have to come through the hole in the skin. The distal limb is opened almost 80% of the circumference. Proximal limb is everted. The functional limb is 80% of the circumference. Generally, rod is not required. With respect to loop end stomas, you can also have a loop end stomas. It is useful when the patient is obese or when you have a short, thick mesentery. Here the bowel is not divided. Stoma rod can be used. The loop end stoma will function like a loop stoma, but it is easier to exteriorize. Okay, and this loop end stoma, this is terminology which has been used in Shakilford. What we generally use is double barrel stoma. This is what we use terminology in our practice. So what you are doing here is, when you are doing loop end stoma, you are not separating both the bowels. Part of the bowel is still attached to each other. So that's why it is easy to extrovert, and then you can easily close it if you want to restore the bowel continuity. So that's about loop end stoma. Okay. So I was telling you about end loop or divided loop stoma. This is how it looks. Some part of wall of the bowel is still continuous. So when you want to restore the bowel, you can do it easily. It looks and functions like a end stoma, and it allows diversion using remote bowel. Stoma takedown without laparotomy can be done. Okay, you can do a restoration of bowel continuity without doing a midline laparotomy. You can just mobilize this from the surrounding scene when you are doing a restoration and just apply a couple of stitches and push it inside the bowel. Okay. What are the types of end loop or divided loop stomas? You can do end loop ileostomy, you can do end loop colostomy, or you can also do end loop ileocolostomy. Moving on to loop stomas, most of these are preferred for temporary diversion. So loop end stomas are useful in obesity or when you have short, thick mesentery. Here the bowel is not divided. The stoma rod may be used and it functions like a loop stoma, but it is easier to extrovert and it is easier to close also. Okay. With respect to loop ileostomy, the ileostomy is done 15 to 30 centimeter from IC wall or from the pouch. Both limbs are bored through the hole in the abdominal wall. The distal limb is opened almost 80% of the circumference. The proximal limb is everted, and the functional limb will have 80% of the circumference. Usually rod is not required. Okay. The advantage of end loop stoma, it looks like a and functions like a end stoma. It allows diversion using remote bowel, but stoma can be restored without doing a midline laparotomy. Okay, you can close it locally and push it inside the abdominal wall and close the stoma site when you want to reverse it. What are the types? End loop ileostomy, end loop colostomy, and end loop ileocolostomy. Indication for loop colostomy: it is indicated for severe incontinence, distal anorectal sepsis, or anal reconstruction protection. So the loop colostomy is done as a temporary method. Okay, in severe incontinence or distal anorectal sepsis or anal reconstruction protection. And once the objective is served, then you are going to close the loop colostomy and restore the continence. But remember, compared to ileostomy, loop colostomy is less preferred because it is prone for prolapse and the function is poor compared to ileostomy. And loop ileocolostomy, it is done when you are done a right colectomy, but you are not in favor of anastomosis because you know the patient is high risk or the anastomosis is high risk. If I do anastomosis, there may be leak. In those situations, you will do end loop ileocolostomy. You are bringing both ileum and the distal part of the colon as a stoma. So here the ileum limb is a functional limb and the colon is just a distal mucous fistula. The major advantages of end loop ileocolostomy is you can do a stoma closure via parastomal incision. You don't have to do a midline incision. It decreases the morbidity and it decreases the recovery time. That is the beauty of end loop ileocolostomy. This is about creation of loop ileostomy with support rod. We discussed about this. So, you are bringing a loop of ileum there and you are going to open the 80% of circumference and you will use this triangular suture and you will avert it, and sometimes you can place the rod if required. Okay. This is the creation of end loop ileostomy. Okay. You have two loop of ileum, the proximal limb and the distal limb, and they are sitting next to each other. Okay. One is a functioning part, the other one is a distal mucous fistula. And again, when you want to restore it, you mobilize it here, do the anastomosis and then push it inside, close the abdominal wall. That is how we will do end loop colostomy, end loop ileostomy, and then how will you restore the bowel continuity in future. Okay, creation of end loop ileostomy. Creation of end loop ileocolostomy. I told you, in the case of right hemicolectomy, okay, you have bought both the ends there. The colonic limb will be distal one and it will be a distal mucous fistula, and the ileostomy limb will be the functioning loop. That is the creation of end loop ileocolostomy.